Thank you once again for giving me this opportunity. I've been entrusted with a very interesting topic for today's discussion, which is my own clinical audit. And this is a 7-year study which recently got accepted and published in Obesity Surgery, and the hard copy will be out this year. So the audit was to find out the effective and safe bariatric and metabolic procedure in our own setup, since we were doing all the 3 kinds of bariatric surgery procedures in our center: the sleeve, the mini gastric bypass, and the Roux-en-Y. So with the introduction, this obesity is increasing all over the world, and India is also now in the grip of obesity. And obesity, we all know that it leads to type 2 diabetes, blood pressure, sleep apnea, etc. So if you see the figures, that India is the 3rd most obese nation in the world, with the figures as high as 30 million. And unfortunately in India, now the problem of undernutrition and obesity, now they are coexisting. So the primary aim of our study was to find a safe and effective surgical policy for bariatric and metabolic procedures, while the second aim was to analyze the complications occurring in the respective procedures. So this is a study carried out over a period of 7 years in our setup by a committee comprising of a surgeon, physician, and a statist, coordinator, and a nutritionist. So for the complication part, we have taken all the 1107 cases over a period of 7 years, and for the resolution and excess weight loss, we have collected the data whom we could follow for a minimum of 4 years. So coming to the complication part, we have taken the data assuming that whatever major complication patient reports to the primary surgeon or the primary center. So the majority of the patients were the female, and the mean age being 46 years. They had mixed proportion of all the comorbidities in a fair good proportion, with all the 3 procedures being done. And the time taken for mini gastric bypass and sleeve was almost the same, while for Roux-en-Y it was twice. The data for excess weight loss and the resolution of comorbidities was for a period of 4 years plus something, and it comprised of 407 cases, with all the 3 procedures and all the 3 types of comorbidities. So we divided our observations into the complication part, out of which life-threatening and non-life-threatening ones, and the benefit, which was excess weight loss and the resolution of comorbidities. Coming to the life-threatening complications, amongst the 3 procedures, what we found in our series, that in sleeve, the restrictive procedures, the incidence of leaks was maximum, and also the incidence of mortality is maximum, that is 2%. While in a Roux-en-Y, distal Roux-en-Y and mini gastric bypass, the incidence of anemia is high. Particularly in mini gastric bypass, we had 13% incidence of hypoalbuminemia, and that too in longer bypasses. So low albumin levels are explained because of the longer length of bypasses. Once we are in danger zone, the danger zone, according to our studies, when you cross 200 centimeter mark, yes, you are stepping into a danger zone. When you are decreasing the absorption of this protein thing, yes, your patients can land up with low albumin levels. And only one of our patients who had 2 centimeter bypass, who had this low albumin levels, was patient of diabetic nephropathy, and even that patient responded to good nutritional support. So in our setup, what we have taken is that if your albumin level of the patients are between 2.6 and 3.5, a good nutrition support can help your patients. They can come out of it. We have so many preparations, including this creon and pincoflat thing. And then the reversal of bypass, if there are persistent albumin levels below 2.5 and patient is presenting with ankle edema and ascites, and it is persistent, not responding to any therapy, yes, then it becomes an indication for reversing mini gastric bypass. So the two cases I discussed in my previous discussion, we reversed. All other cases of mild hypolipidemia, they responded to good nutritional supplementation in the form of good protein diet and did not require any surgical intervention. Now, as a matter of fact, we have tailored our bypass length to 200 centimeters and we do not found any persistent hypolipidemia in these patients. While if you have low albumins in distal RNY, if you go to revise that, it's a little difficult and long and cumbersome surgery. You have to revise to anastomosis. So that is a little difficult in RUNY as compared to mini gastric bypass as per hypoalbuminemia part is concerned. Amongst the non-life threatening ones, again we found in sleeve only, the incidence of reflux or the weight gain was highest as compared to the RUNY and mini gastric bypass. And inadequate weight loss, about 13% people had inadequate weight loss. And of course, the nausea because of high intragastric pressure and acid reflux, the incidence is more. So if we compare the end result, the excess weight loss and the resolution of comorbidities, we found that amongst the three procedures, the mini gastric bypass superseded the other, be it with the weight loss or the dyslipidemia or the type 2 diabetes correction or the blood pressure. So our results varied from 50s in sleeve gastrectomy to 70s in RUNY to 90s in mini gastric bypass. So our audit indicated that the mortality was maximum in sleeve series and least in bypass series. Leaks were highest in sleeve series. Persistent vomiting only remained in sleeve series. Weight regain was highest in sleeve series, that's 14%, followed by RUNY 8%, and almost nil in MGB if we go by Reinhold's criteria, that is excess weight loss more than 75% at the end of 7 years. The low albumins were minimal in the restrictive surgery, that is sleeve, and maximum in distal MGB, longer bypasses, and the resolution of comorbidities was again maximum in mini gastric bypass. So why we prefer mini gastric bypass is that weight loss is maximum, mortality is nil, 30 days mortality is nil in our series, weight regain is least, the resolution is maximum as compared to the other two procedures. So we have shifted almost all our cases to mini gastric bypass unless there are some real contraindications to the procedure. So we conclude that mini gastric bypass, which is combination of this restriction and malabsorption, is technically more easy to do than this RYGB, and the mortality is least, and excess weight loss and the resolution is maximum in our series in mini gastric bypass. So we recommend that MGB should be the procedure of choice with morbid obesity, but it's got an attached but to it. You need to follow your patients because of malnutrition or some other problems. Sleeve may be recommended where malabsorption is contraindicated, and with a word of caution that there is weight regain in that series. If we compare RNY and MGB, I prefer MGB because of its simplicity, reversibility and revisability.
Thank you, Dr. Jammu. It's obviously an elegant study, and I know you've also published your data, but you have stepped out of your time, so that will not leave us many questions in the audience. But if the panel have any questions, please feel free, sir. If anybody on the panel wants to ask anything.
Did you have any differential policy in terms of DVD prophylaxis, and what was the bleeding rate comparatively in the three groups?
We have the same DVD prophylaxis policies in our setup. We give the pre-op low millimolar heparin and follow for at least 7 days even after the surgery, even when patients are discharged. Then we have this intermittent compressive devices, then elastic stockings, the same prophylaxis, be it with sleeve or any bypass procedure, same prophylaxis for any patient.
Thank you. And one last question, Dr. Tatia, please.
I will stop with other procedures.
So we do sleeve in where this malabsorption is contraindicated, like in young patients or patients with we are scared of we may develop some cirrhosis in the future, like liver problem.
Thank you, Lauren. Thank you, Dr. Jammu. With this, I will now invite Dr. Anu Singh from Fortis, Delhi. Dr.